Welcome, and thank you for attending our webinar. I have some housekeeping notes before we begin. Because of sound quality, it's necessary to keep you muted throughout the program. You have the ability to ask questions using the questions box on your control panel. As a provider of continuing education, ICS follows specific guidelines and regulations when presenting continuing education events. We appreciate your professionalism and honesty in accurately recording the number of CE hours you attend during any given program. We recommend you be on the webinar screen for the full webinar. The system can tell if you pull up another screen, such as your email, and will show you as inattentive during that time. ICS bases the amount of time you're attentive when considering your CE hours. Polling questions are asked during the webinar. They are also used to gauge your attendance in CE credit hours. You must have your pop-up blockers turned off or hold down your CTR up key in order for the polling questions to work properly. If the polling questions do not function for you, simply write down the question and your answer in fax or email it to me, or type your answer in the questions box. An online survey will display on your screen when you leave the webinar. Please take 30 seconds to provide us with valuable feedback. Today, we welcome Dr. Ted Arkfeld to assist us in implementing ICD-10. This is a 2-hour webinar and the last in the series of 4. We will be taking a 10-minute break at about 1:30. Dr. Arkfeld graduated from Northwestern College of Chiropractic in 1988. In 2007, after being in clinical practice for over 19 years, he became a certified professional coder and full-time compliance consultant. In the fall of 2010, Dr. Arkfeld and Genius Solutions launched the National Academy of Chiropractic Coders. This is the first national organization to provide education and a certification for doctors of chiropractic and their insurance staff. He has also authored 2 textbooks and is a much sought-out speaker for state conventions. Join me in welcoming Dr. Ted Arkfeld.
Thank you, Denise, and welcome back, everybody. It's hard to believe that we're on our final session here. These 4 weeks have gone by very quickly. So what we're going to do today is we're going to go over a review, and then we're going to put into practice translating the codes. And so it's this is just a start for you, and I encourage you to continue to research ICD-10 and play with it and practice with it. We do have, and we're going to be offering a substantial discount to all attendees through the National Academy of Chiropractic Coders on our website. It's called correctcodingpays.com. Either call our office at 989-448-8065. Let them know that you were an attendee on these sessions. And we have a 5.5-hour online home study program just for ICD-10 with quizzes at the end. That normally runs $700, but as attendees we're taking $100 off, and so your cost would be $600. And we're going to be adding to that, so there's going to be more hours that will be brought on as the time goes on. So you know, I urge you to continue on because, you know, yes, we're about 1.5 years out, and you go through all this right now, and then if you don't keep just, you know, chipping away at this translation and transition into ICD-10, you could forget it and be starting all over. So one of the things that I highly recommend is that you start having office meetings, or you can call them ICD-10 parties, and start coming up with some games on translating your current ICD-9 codes over into ICD-10. You know, so you want to keep this training going full force now in preparation, because this is the only time you're going to get to practice. From now until October 1st of 2015, this is the practice sessions. There is no grace period. So we're going to go from one language, ICD-9, to ICD-10 overnight when October 1st, 2015 comes. All right, we've got the disclaimer that you've seen on every session. Basically, everything is provided and based on CPT codebook, ICD-10 information found in the ChiroCode desk book, and any other documentation requirements, Medicare manual as it relates to chiropractic practice. Once again, the two books especially the ICD-10 coding for chiropractic, it is a must resource for right now. I hope everybody has theirs with them today because we're going to be doing some practice sessions at the end here. So I'm going to be giving you ICD-9 codes and having you translate over into ICD-10. Since this is the last session, please ask questions. I just came from up in Marquette, Michigan over the weekend doing a seminar up there, and the crowd was great, and they asked a lot of questions, and that's what we're going to need to do. We need to keep learning and keep moving on. How to implement, so we did find a code. So this is a free app for your smartphone, and this is a way to get started with the gyms. Now, please do not get lazy with this coding and just think that once you plug it in here, find a code that you've reached your final destination. From previous sessions, remember that this is just the start. This is just where we're going to start that mapping translation over into ICD-10, but you have to finish at the tabular list. That is going to be the most specific code. And ICD-10 is all about specificity. I believe I said it in the very first session. I love ICD-10, and I know that a lot of you are feeling frustrated and everything with this, or a little anxious, but I really do love it. The more I teach it, the more I learn about it, and I'm continuously learning more things about it as well. From a clinical standpoint, the more I really like it, because it does bring in things that we see clinically. As a diagnostician and a clinician, we see these things. Now we have the codes to report. Overall, I think ICD-10 is going to help us thwart some post-payment audits. I think it's going to help us explain why our Medicare patients who have been patients of ours for years are coming back in periodically, maybe with the same condition, because of the etiology codes, and those are the codes that we went over on the last session. From a statistical analysis, I hope that ICD-10 provides us with the medical necessity for our care and shows that our care is effective with other cases. And one of the things that I'm going to start doing is at the very last, when ICD-10 does come in full force, and we've actually, I should say that I've started this already, we are starting to report comorbidity, things like diabetes, hypertension. Now, I'm not making those diagnoses. Patients are coming in, and when I'm taking the past medical history, they are relaying the fact that they have been diagnosed with diabetes, hypertension. I have one patient that has systemic lupus. Do these other conditions, do they affect, or could they affect my treatment plan and the recovery of the patient? By all means. And so I'm going to start putting those on at the very end of the claim form. We started doing that to a limited extent with some of our Part B. I had a patient that came in a few weeks ago and had a lot of comorbidities. He was hypertensive, past medical history of prostate cancer. He had surgery on the lumbar spine. So I did put in the diagnosis of diabetes at the very end. And the reason is because he came in with bilateral leg pain. I don't know if this is part of the diabetic neuropathy or if it's spinal stenosis Is it intermittent claudication? There's a lot of things could account for that. But I wanted Wisconsin Physician Services to know I'm treating this kind of case and that it could possibly delay the improvement for the patient.
Dr. Arkell?
So, yes.
We have a question about the ICD-10 coding book. A doctor says we have the ICD-10 coding for chiropractic code book, but it is the first edition. I see Dr. Arkfeld uses the second edition, and he references pages that are not the same in the first edition. Do we need to update our book?
Not necessarily, no. The codes, I don't, I have the first edition too, and we sell the ICD-10 book. So when they came across, I just started using the second edition. I don't believe there's going to be, the codes haven't changed. I think there was just more, maybe more explanations between the first edition and second edition. But as far as looking up the specific codes, I think you'll be just fine with the first edition. So when we first started this journey, and I have called our seminars on ICD-10 the road to ICD-10 because that's really what we're on. And when we first started out, I know that you felt like this. You sit there going, oh, what are we doing? This is going to be such a monumental change. We're going from speaking one language to a totally different language, and how are we going to get this coding down? How are we going to do the documentation? All these changes that were occurring because of ICD-10. And I hope by now that some of the frustration, some of the anxiety, some of the fear of the unknown has been taken away with these sessions. Are you there yet? Have you reached the final? No, I'm not there yet with my own practice. So everybody's going to have to determine how are you going to implement this into your practice. And that's what you need to start thinking about in holding meetings. You need to get everybody in your office involved, especially the billing side and the doctors. And so you come up with an implementation plan. I know that there's been some other instructors on ICD-10 to recommend that you go get a line of credit of $20,000 to offset any losses. I don't necessarily agree with that, and I can tell you I'm not going to be doing that. I believe that we have enough time now to get everything ready so when October 1st comes, 2015, you're ready to go. It's just, it'll be really, I think, that easy, that if you do all your training and your planning and implementation, that you're going to be good. You'll get through this. It's just another change in healthcare. We've gone through them before, and this is just another one that's coming our way. And I think once we get down a few months into the usage of it, it's going to be, man, what were we so stressed out about? It is going to require some help from your practice management software, and if you have an EHR, some help with tools from them. And I know most of the EHR vendors are working on those tools right now to make this transition more easy. So let's just go through a review. ICD-10, it will replace ICD-9 on October 1st, 2015. All right, so this is actually the second delay. It was originally started to go in 2013, then they delayed it to 2014, and then just a few months ago they delayed it to 2015, which this is going to beg the question, are they going to delay it again? And I am not going to tell you that they're not. I was for sure that they were not going to delay it this time. So I am not going to tell you that. All indications are that they're not going to delay it again, but I cannot say for certainty that they won't. My advice, and this is the advice of everybody that is dealing with this, you code on. You code on, keep training, keep planning, and be ready. So mapping. Mapping is a type of crosswalk to find the corresponding diagnosis codes between ICD-9 and ICD-10. So in your ICD-10 book, the second edition, or if you have the first edition, if you can find the corresponding, if you take a look right now, so I am looking at, if you look at the pages, it starts on page 57, and that's the beginning of our code map. And so you'll see on the left side the ICD-9 codes, and you come straight across and you'll see the ICD-10. And so it gets you to, this is just the general equivalent mapping. So remember, you don't stop here. You would never end at this section for the most appropriate code. I guess you could if it came to a pain diagnosis like cervical spine pain, thoracic pain, lumbar spine pain. There is only one-to-one equivalent in ICD-10, but that's not going to be the case for all others. So please keep moving. Just start here. That gets you to the first 3 codes, and then you move back into the book, into the tabular list to find the most specific code. There are visual differences, as you're well aware of by now. The typical 5 numbers that we have grown up with ICD-10 has now been replaced. It's alphanumerical, and it can contain up to 6 to 7 characters. There could be X's in there. Those are called placeholders, and that is to allow for future growth with ICD-10. So if you see in a code an X or 2 X's, you put those in. That's the most appropriate code. So there is noticeable visual differences. I have equated this from speaking English on September 30th, 2015 to speaking French October 1st, 2015. Totally different language. The GEMS, General Equivalent Mapping System, refers to mapping files that crosswalk from ICD-9 to ICD-10. You start here. So if you have the number, then you can start here with your mapping. And then again, you end at the tabular listing. If you don't have the number, then you start with the alphabetical index. So doctors, if you don't know the numbers, and quite often you get out to some of the most our frequently used diagnosis, like our subluxations, the 739s and the 839 series, we know those very well, but we get out to some of the others, say disc herniation or degenerative disc disease. Right now, go through your office, find the most specific codes that you're using. And if you're using the cheat sheets, you know, as I stated in the first session, you're not going to be able to use cheat sheets when ICD-10 comes into play. It's just too many codes. And your cheat sheets will probably be the same size as the ICD-10 book. So I guess if you need that, your ICD-10 book is going to be your cheat sheet. So start right now reviewing your diagnosis codes that you use. And we discussed about the fundamental of the coding. There's certain things you can even start now using with ICD-9, you know, such things as the hierarchy of the codes and the coding sequence. So the hierarchy of the codes would be neurological diagnosis, structural, soft tissue, and pain. And you'll put that down for every condition that you're seeing a patient for. We now can do that very easily because we have 12 diagnostic slots in our claim form. You know, so it's super easy to do that. I am seeing across the country some carriers, especially the Part B Medicare carriers, they are denying claims because there's not enough diagnosed to match the levels of manipulation. 98942 should have a minimum of 10 diagnoses. 98941, your 3 to 4 area adjustment, should have a minimum of 6 diagnoses. And 98940, 1 to 2, should have a minimum of 2 diagnoses associated with that. So again, it's very easy now for us to do all the diagnosis or input those with our new claim form. And I think right now, Denise, I put these in at various times. We can go with our first polling question.
Wonderful. Okay. We're going to put that on yes. Okay. I am going to, let's see, I got to make sure I got the first one up. I'm going to launch the poll now. Hold down your CTRL key. So the question should be up there, and of course, if this is a recording, the polling questions don't function. They're made part of the test that you received with your voucher. So the transition to ICD-10 can be delegated to your billing staff, and everything will be okay. Is that true or false? Oh, we're almost 100% voted. There we go. I'm going to close the poll. And
oh, you guys are good.
The results, I know. That one was easy for them.
Yeah, I gave you an easy one. Okay. Yes, just to go over that again, some of the thing, I'm worried that anybody that didn't attend these sessions, that the doctors are just going to think that they can delegate this to a billing staff, that they can just say, okay, our ICD-9 codes, toss them an ICD-10 reference or resource and say, hey, translate and just let me know. We're going to just keep going. And that is not the case. I think that you have found in the previous sessions that really ICD-10 is going to be driven by your documentation. You know, and like no other time before in the history of chiropractic, it's going to be absolutely necessary that through your documentation, through the interpretation of your orthopedic and neurological tests, the documentation of what those tests were really eliciting and how the patient's response to those tests is going to drive the most appropriate diagnosis. You know, and with our diagnosis right now, if you start using the correct fundamentals, and again, the hierarchy, for every condition, you would put the primary complaint or the chief complaint. You'll list all the diagnoses that could correspond to that chief complaint on the new claim form. And then the secondary complaint, and then the third complaint. You know, so that you could have 12 diagnoses on that claim form, depending on what the condition of the patient is. You know, we're going to review again the vertebral subluxation complex and how to break that up into the individual components, spinal-kinesial pathology, and then what's the specific code that would correlate with spinal-kinesial pathology. My goal through this whole process, and what I get the most fun out of, you know, the thrill out of coding, and I know that some of the doctors are probably rolling their eyes right now. How could coding be thrilling? How could this guy get fun out of coding? I like bringing the clinical side and finding the correct code. That's what I think is fun to do. And then if you do that, then I like to match those codes with our procedure codes, and in the most compliant, ethical, and moral fashion, get the reimbursements that you deserve for the work that you're providing. Are we ever going to be reimbursed wholly for what we deserve for what we do? No, there's no way you can put a price tag on that. But coding has been such a problem in the profession, and that's not my personal opinion. This has been reflected in Office of the Inspector General, OIG reports, that we have not graded out really well, and that has launched post-payment audits. And right now, I know that this is happening in Iowa and it's happening here in Michigan. We have doctors that have been put into prepayment reviews for their full spine adjustments. So the answer to all this is correct coding and proper documentation. That's how we fight all this. All right, moving right along. So there is specific documentation requirements for every condition that we're going to treat. And I can tell you right now, that is the third book that I'm working on. We're going to be, I think it's going to called Correct ICD-10 Documentation or something like that. So that's my summer project. Myositis. All right, so right now, if you were to use this, this is an inflammation of the muscles, mostly caused by autoimmune conditions. If you go to page 209 in your ICD-10 book, that would equate to M60.8. And so you get to there. And I want you to go ahead and start flipping through the pages to get to there, because I want to point out when we get to the tabular list. So you'll see on page 220, well actually it's not page 209. Let's see. Yeah, that is not right. That may be in the earlier edition. So do not follow those pages. That may be in the earlier edition here. It is. All right, so actually page 222, and we have disorders of muscles M60 to M63. And you're going to see once again your excludes 1. If you remember, anytime you see excludes 1, you cannot code what's ever listed in the excludes 1 list with the code you're looking for. You can't do that. Now, excludes 2 may be a condition that is associated with the condition you're trying to code for. But just remember, excludes 1 never go together. So we go to M60.8, and we get up there and we see other myositis. So M60.80 is actually the most correct code you would use. That's the reason you can't just end at the gyms. You got to get back into this tabular listing, and you got to dig through to find the most appropriate code. So we even have laterality. If you remember, we can do right shoulder, left shoulder, and we have M60.811, other myositis, right shoulder. So that's the beauty of ICD-10. We have a lot of specific codes for what we're seeing clinically. Muscle spasm. Right now, if you're, yeah.
Hi, just one comment. I had a doctor type in, I have second edition and myositis is on page 209. Are there two different sections for that maybe?
Because I am seeing on mine, I've got 222 that I was actually looking at, and 209, this would have been if it was an autoimmune disease, the myositis. And the other one is anything, the 222 is anything that it did not have to do with an autoimmune disease. That's the difference.
Thank you.
Okay, so right now, muscle spasm. When I talk about the documentation being very specific and leading us to the most correct or specific diagnosis, you start that right now. And so on your objective, your spinal exam, part exam, whatever you want to call it, when you palpate the muscles and if you document that there was spasm, the only code that you can currently use for that would be 728.85 in ICD-9. So if you go to M62.83, and again, I'm sorry, those page numbers are not correct on here. So if you go to M62.83, that's going to be the beginning of the muscle spasm. And so what we're going to do, and I'm looking up right along with you here, M62.83, and so we see muscle spasm, and then we get to M62.830, muscle spasm of the back, M62.831, muscle spasm of the calf, and M62.838, other muscle spasms. Now, muscle spasm of the back. For ICD-10, M62.830 is going to be the code you would use when you find muscle spasms in the thoracic or lumbar spines. That's going to be considered the back. The other muscle spasm they're talking about, M62.838, will be if you find muscle spasms of the cervical spine or cervical paraspinals. So when you go from muscle spasm to muscle hypertonicity or myalgia, myalgia is going to be the same as muscle hypertonicity, tender to palpate the muscles. It's anything that is not a muscle spasm. Muscle spasm is going to reflect more of an acute nature or recent trauma. Okay, so you can go from 728.85 in ICD-9 to 729.1 right now. When we get to ICD-10, you're going to use M79.1. And M79.1, now in my book I have that as page 245. That's going to be listed under myalgia or myofascial pain syndrome. And you're going to see right underneath there, excludes one, is going to be fibromyalgia and myositis. So you can never code those two with M79.1. So now we get to the etiology, which is the causation of your patient's symptoms. So remember, the etiology is going to be an important for correct code selection ICD-10. It's going to be very important to list those etiology codes in your auto and workers' compensation cases. And it's going to be very important for Medicare, because as we went over before, Medicare is starting to label returning patients as supportive care. They don't understand that when a patient's structure has gone into a degenerative process, the threshold for injury or re-injury has been lowered. And so those patients naturally, when they're out, and especially now, everybody is very active outside, it's going to lower those threshold, and the patients are going to come back in. And I had the question this weekend, well, do you need to change the diagnosis if they come back in? You call it like you see it. If the patient returns with the same condition, low back or same area, and you do your history, your examination findings, and you find that there's been no change in that diagnosis from when they were previously in for active care, you go ahead and keep the same diagnosis. What is going to help us with ICD-10 is that you're going to put that etiology of what caused this flare-up. We're going to have codes that are going to be able to explain what they were doing, and that is going to help us, I believe, from a statistical analysis and help us move from a supportive care interpretation by the nurse case reviewers to active care or active treatment. And if you go into your chapter 20, you'll see all sorts of examples of these external causes of morbidity. You know, this one here, this fall from the Heelys, colliding with a stationary object, other Healy accidents, and you know, we showed the videos last time of all the different weird things that they have, fall from a roof, hand gliding accidents, all these. You name it, and there is a code for an external cause. And especially when it comes to auto cases, three-wheeler accident, pedestrians, home accidents, injuries, you'll be able to find those causes. Remember, for any of the traumatic diagnosis, you're going to find a seventh character extension. And this is going to be especially true for our traumatic subluxations, the S codes, and we're going to have A for an initial encounter, D, subsequent encounter, and S for sequela. So when you have a new patient or you have a returning patient coming in with a new condition or an exacerbation of a previous condition or an aggravation, and it's a result of some kind of traumatic event, you will always use the A when you send in that initial visit. The A will come off when they come back in for subsequent visits, and that'll go to either a D will be placed in that seventh character or an S. I warn or caution you, I should say, on the sequela use. My fear is that could be a basis for a pre-existing condition, and I fully am aware that there's proper coding, there's proper documentation, and I've been telling you to call it like you see it. However, I am also fully aware of the real world of how some insurance companies work. And if they can pin anything on a pre-existing condition, it could make, you know, it could cause some trouble for your office. It could make things very difficult. The reason is that they always try to blame the causation on something else, and the use of sequela could actually foster that that notion that this was a pre-existing condition. And you know, I do want to talk about pre-existing conditions very quickly. They can be explained away in your documentation. So if you're finding that you're running into this with your auto or workers' compensation cases especially, you know, let's say that a patient was involved in an auto accident and they have degenerative disc disease, or they have spondylosis, osteoarthritis. You know, those are things that have been there, and obviously that is a pre-existing condition. What you always need to determine is, were they symptomatic? You know, most of the time the research has shown us, and especially when we're talking with disc herniations, that there's a large number, 60 to 70% of the people walking around right now with MRI evidence of disc herniations. However, they're asymptomatic, but that would be considered a pre-existing condition. So you need to be able to tell the story of the patient in your documentation that they were asymptomatic at the time of the trauma or the injury. And as a result of that trauma, now they're experiencing this type or these types of symptoms. So let's say that they were symptomatic prior to the injury, that they were having stiffness and soreness, and that their scale of pain was, let's say, a 2 or a 3, and it was intermittent stiffness and soreness made worse by certain movements. If you have that all spelled out in your documentation, and now they were involved in an auto accident or a workers' compensation case, and that symptom now has increased to constant, their pain level has increased to a 7 or 8, but more importantly, the quality of the pain has now changed. It's now gone from stiffness and a dull ache to maybe sharp, throbbing type of pain, shooting pain. That means that it's changed. The pain has actually changed, and now you can take and use the causation as the new aggravating factor. So we get into sequela. I would, again, just caution the use of that. I would probably lean more towards using subsequent encounter D, especially if a patient has been involved with a previous injury. In some cases, though, I'm still going to tell you to call it like you see it. If you really feel that there's residuals, and that's what sequela is, they are residuals left over from some previous trauma. If you firmly believe in the best clinical judgment that that's what should be used, that's how you code it. And then just document very well in the patient charts to support your findings there.
Dr. Arkfeld, we had a couple questions that came in, and we may jump back a little.
Okay.
First question, does the etiology code just get used once for that visit and then removed for a follow-up, or does the etiology code follow the claim throughout the treatment?
It follows the claim throughout the treatment. So the main etiology code, let's say it was an auto accident and it was a semi-truck driver and whatever that code is, that will stay on, and it's always the last code that you'll use. Those are what we call a secondary code, but that will stay on throughout the whole course of treatment. Now there's other ancillary codes that follow episode, or the etiology I should say, and that's going to be the place of occurrence, the activity. Those codes that we went over last week, they will drop off after the first visit, but the main etiology code stays with that claim until the patient is released from care.
Okay, another question. Has it been established that initial encounter is the first visit to your office or the first visit to any doctor for that particular condition?
Excellent question. And what we're really talking about with that question, we're talking about box 14 of the claim form. And box 14 is extremely important. And so let's go over that. We're just going to digress a little bit and talk about that. To answer the question, with your auto and your workers' compensation cases, the date is always going to be the date of illness, injury, and I think it's pregnancy. For your auto and work comp, that is the date that they were involved in the trauma. So if they come into your office today, but the accident happened, let's say Friday, it would be June 6th, would go into box 14. Again, that's only for auto and workers comp. I want to be very specific on that so there's no misinterpretation. For all your other financial classes of patients, your Medicare patients, your group health, it is going to be the date they present to your office for that condition. Or, in other words, what the reviewers are thinking, that is the date that they started the treatment plan for that condition. So they may have had the onset as last week. So let's say Friday, you have a Medicare patient comes in today, and they said last Friday they were out doing yard work and that's when it started. You wouldn't put the date for last Friday. You put the date that they came into your office, which would be today. And that's the date they're starting their treatment plan for that condition. Now what Medicare, the manual states, is that doctors of chiropractic are afforded the opportunity to treat and arrest the condition within a 90-day period. That does not mean that after 91 days that automatically you're going to be red flagged, you're going to have auditors come sweeping down. They just kind of give you a ballpark. So that box 14 is really big. So you should, after we get done with the session today, what I would like you to do is go and all your patients that have been coming in for years, or even over the last year, Go look at whatever practice management system you have and see what Box 14 looks like. If you haven't changed that, that could be a red flag for your office, because what you need to do every time a patient starts up in a new active care program, whether they're Medicare or group health insurance, whenever you're bringing them out of wellness or maintenance care into active care, and you're providing them with a care plan, and this is based on either an exacerbation, an aggravation, or totally new condition, you need to change Box 14 on the claim form. So that's stating that we're starting up with a new treatment plan. If you go back and find Box 14 has not been changed for years, that's telling the insurance company you're still treating them for the same condition that they came in with 5 years or 10 years ago. And I've come across this in other offices. I've come across where they have not changed Box 14. Now, is this going to be a basis of an audit? That I don't know. I know that they have placed heavy emphasis on Box 14 when it came to an OIG report back in 2009. They stated that we weren't changing that like we should. I think it could be one of the elements that they could screen for. And then if they see that that date hasn't changed, they could automatically assume that the patient is going into supportive care. And obviously supportive is equals maintenance or non-covered services. So another important factor about Box 14, what do we do with the patients that come in one time a month, or they just pop in because they have an increase in stiffness or soreness, and you don't feel comfortable with presenting to them your wellness or maintenance plan? Well, there's a couple ways to do this, and I want to refresh the definition of medical necessity per Medicare, and pretty much everybody else follows along with this. In order for the claim to be considered acute or active treatment, a patient must have a neuromusculoskeletal condition, and it must necessitate care. And then the subluxations found must be causally related to those symptoms, and that condition must be causing an alteration in their normal functional activities of daily living. So we all have patients that come in like on a monthly basis or every 6 weeks. If they do not have any change, or if that condition is not progressing, then you cannot submit an insurance claim. You've got to tell them that this is considered supportive care or maintenance or wellness, and they're going to have to be financially responsible for that. However, if you do have patients that come in and that they've had a flare-up, so you may treat them 1 or 2 times, and then they just happen to show up every month, you better make sure that you have a pain scale on them, you have a neck disability or oswestry filled out, and that you can show that there's been a spike in their pain level and a decrease in their functional activities of daily living. You would then go through and you would need in your documentation to state what your treatment plan would be for that patient. Remember, treatment plans are just plans. Nothing is set in stone. And so I have patients that come from about 60 miles away, and due to gas prices, they're not going to come daily or 3 times a week. They can't afford it. I always document when they show up every 6 weeks or every month. They just it seems to be every 4 weeks to 6 weeks. And I also put in my notes, return as needed. I don't put in my notes, we'll see them again in 4 weeks. Because if you do that and you schedule them in 4 weeks, if those notes were ever to be reviewed, I can tell you if I was reviewing them for Medicare, I'd say you're putting these patients on a wellness or supportive plan, and that isn't covered. So when those patients come back in, they have a flare-up, aggravation or an exacerbation or a new condition, you need to do a new history. And I know I'm going way off topic here, but you must follow the Medicare manual for initial visit must-haves. Initial visit is not the initial encounter into your office. It's the initial visit for that new condition. And that's why there's specific documentation required that Medicare has in their manual, and that's the reason it will correlate to box 14 on the claim form. So you're going to go through and do that history, those history requirements, and one of the biggest things with that is that you need to document the location for every symptom, and you need to document the mechanism of injury. And then you go through and do the rest of your history. You'll do your examination. The diagnosis may have changed, it may not have, and then you put them on a treatment plan. The treatment plan is one of the biggest areas that we are getting hit with negative results in post-payment audits. We do not typically do well with those. We will put down a treatment duration and frequency, but that's all it is. It's just a treatment frequency. You must have in your treatment plan listed out all the procedures that you're going to do or have done on the patient and why. Why are you going to do these? What do you hope to obtain, and what are the objective measurements you're going to use to support your care plan? Some of the objective measurements is going to be, and I know this is really a subjective response by the patient, but it's going to be your pain scale. They want to see that that pain scale is going down. Pain is not enough, though. Once you get a patient down and they're not making any advances in their recovery, they're not decreasing their pain, they may have hit a stable or a plateau, and at which point, again, they could be considered supportive or in maintenance care. You need to put in new neck disability and oswestries, and that's going to give you numbers, and that will also take you from a higher baseline number when they first came in, and as long as those numbers keep coming down, you have the medical necessity to keep treating the patient. Do your re-exams or do the neck disability and oswestries every 30 days. And coincidentally, that's what PQRS is, the Physician's Quality Reporting System. I think that they have kind of forced us into PQRS because we have not done well on reports. And so that's just my personal opinion, that they've kind of set up the PQRS system to say, okay, chiropractors, and it's not just us that have to do that, but I think they've really targeted on us that, okay, hey, we're going to now make you report these codes stating that the patient does have pain and that they do have limitations to their functional activities. By the way, when the patient first comes in with that new condition and you start off with those new G codes for PQRS, you better have changed box 14. So then you go through and you put in, I would like to see the patient 3 times a week for 4 weeks. Treatments are going to consist of, and if they can't do it, then you would just put in, and this is what I put into my plan section, patients stated they cannot do this treatment plan due to the cost of gas and that they live 60 miles away. And that's how you really buffer why they're not going through with your treatment plan. So if nothing else, get that written in your files. If you were to be audited for these patients coming in 1 time a month or whatever, and they do have an aggravation, they do have an exacerbation, they do meet the medical necessity requirements, then you'll be changing box 14 when those patients come in, okay, because it's a new condition, it's a new exacerbation. I know that that was an extremely long-winded rendition on box 14 and when is the initial encounter of the first visit. So I hope I answered that. That's it's a very, very important topic right there. Any questions on that at all?
Doesn't look like there's any questions.
Okay. I guess for a copy of that transcript, send $3.99 to Dr. Ted Goes on a Rant, huh? You know, the one problem with webinars is I can't ever tell if you guys are laughing at my jokes. So, or maybe that's a good thing. All right, Chapter 13, Diseases of the Musculoskeletal System and Connective Tissue. So we are going to be dealing with the musculoskeletal system primarily, right? And there are numerous changes related to the documentation and coding of conditions in ICD-10. Site now plays an important role, and documentation of the specific site as it relates to the spine is now required. There are vocabulary changes. Neuritis radiculitis goes into radiculopathy, backache, dorsalgia. Spasm, especially in the extremities, is going to be considered contracture. And Facet syndrome is going to be called a dorsopathy. Cervical spine sites, you're going to have to list out in your documentation in order to arrive at the most specific code for many of the codes we're using now or conditions we're seeing now. So you're going to have to determine occipital, lanal, axial, mid-cervical, cervical, thoracic. Thoracic spine sites, thoracic region, thoracolumbar. And then lumbar spine sites, lumbar region, lumbosacral, sacral, sacrococcygeal. Again, we talked about laterality in the past. So there's laterality with our extremities, especially with our sciatica, arm pain. You're going to have to make sure that you document is the condition acute or chronic, or an acute exacerbation of a chronic condition. Our episode of care that we've talked about for traumatic. Osteoarthritis has multiple codes and multiple categories. This is a huge section in the musculoskeletal chapter, and it starts at M15 and goes through M19. There are now specific codes for primary and secondary OA, and again, laterality comes into play for many of these codes. So if you have osteoarthritis of the right hip, make sure you find that correct code in the tabular listing.
Doctor, we did have one comment from earlier. PRN does not work for railroad Medicare. So
okay.
Caution on that. And I think WPS Medicare wants more of a treatment plan than just PRN as well.
I don't know of anybody that will do a PRN, to tell you the truth. You know, basically when I put a return as needed, I will typically state that the patient has been released from active care. And so what I'm doing is having a drop-off. That's where we know that there's a cutoff from their active care plan. And so, and that even goes, if I have a patient that I'm seeing that just pops in and I say, you know what, I'd really like to see you more often, they go, no, I don't have time, or no, I'm not going to do that, or whatever. I will put return as needed, but I'll also, even if it was just one visit, that one visit could actually be all it took, could be the care plan. I'll say patient is released from active care, return is needed. And so if I was ever to be audited or reviewed and they'd say, well, where's your care plan? I said, took one visit. All right, let's get into an example. We have a 61-year-old female presents to your office with ongoing right hip pain and stiffness. Patient said she had a soft tissue injury to her right hip 6 years ago following a bicycle accident. X-rays at the time negative for fracture. So today she has tenderness to palpation in the right hip, positive Patrick's test on the right, reproducing the hip symptoms. X-rays of the left hip were unremarkable. However, the right hip showed sclerosis of the superior aspect of the acetabulum. Diagnosis, post-traumatic, this is following that bicycle accident, osteoarthritis of the right hip. And so we have our ICD-10, and I used our segmental somatic dysfunction lower extremity, and that our unilateral post-traumatic osteoarthritis of the right hip. you could, another example, another possible coding scenario here, since this is a sequela, let's say this is the most specific diagnosis because now there was no trauma involved with the onset of her complaint of hip pain, but let's say there was. Now, after you would use A for the initial encounter, this may be a time where, because you think there's a residual left over from that bicycle accident, that could be a possibility for using sequela in there. Spondylosis is a stiffening or fixation of the vertebral joint with fibrous or bony union across the joint resulting from the disease process and affecting the vertebrae, intervertebral disc, and soft tissues of the spine. It can cause radiculopathy and myelopathy. And this is another aspect here. We're seeing more without myelopathy or with myelopathy diagnosis in ICD-10. Spondylosis starts at M47, and then there's going to be the documentation requirements. Identify the condition. Is it anterior spinal artery compression? Is there spondylosis with myelopathy, spondylosis without myelopathy, spondylosis with radiculopathy, or unspecified? So that's where you're going to have to really go in with these arthritic patients and dig to find the most specific diagnostic code.
Okay, we have a question. What about the subluxation level with the previous example?
What can you go into more detail with that?
I'm waiting to see if he types some more in.
So the previous example, were they talking about this one right here?
I'm not sure. How will you code it? Yes. So yes,
This is
there.
Yeah. If this was a patient of mine, and we're in October 2015 now, and there's no spinal, this is how I would, here in Michigan, this is how I would have to code it. I have to put, in Michigan, I have to put the segmental or somatic dysfunction first. If I'm not in Michigan, what I would do is put this primary M16.51, because let's go back to that hierarchy of the diagnosis. There's no neurological diagnosis going to come from this example. So we don't have a neurological diagnosis. We go right to structural. This would be the primary structural one. So I would use actually M16.51 in the number 1 slot. And then I would use M9906 in the secondary slot. I would probably also put, now there wasn't any, let's see, just from what we have here, there is no soft tissue, so there would be no soft tissue diagnosis. I would put another diagnosis and say it was right hip pain, whatever ICD-10 that would be. That actually brings up a good point. When we talk about the hierarchy, again, neurological, structural, soft tissue, and pain. Even with your structural, there can be a hierarchy within there. So the structural, some of the diagnoses that carry more weight is going to be your disc herniations, is going to be your degenerative disc disease, your facet syndromes. So let's say in the absence of all those, what could you put down for structural? That's when I would come in and I would put in my segmental or somatic dysfunction. I would put in my subluxations at that point when the others are not available. And these are spondylosis documentation requirements. So we have the site, and again, these are the same sites that we just went over. So be sure on your x-rays, and this diagnosis, spondylosis, can only be documented per x-ray or MRI or CT. And here's an example of our various diagnoses with spondylosis. So you have radiculopathy, lumbar region, lumbosacral. That's why you have to do your muscle strength testing. You have to do your dermatome testing, because you have to find the right dermatome. You have to find the right nerve root that is responsible for that. I think, Denise, are we ready for a 10-minute break right now?
Yes, that sounds good. Thank you.
Okay. Alrighty. We'll take a 10-minute break and come back at 1:45. Is that right?
That's right.
Okay.
Thanks.
See you then.
Okay, are we ready to get started?
I am ready if they are.
All right.
Okay, you know what? I see we have a question. Is the Find a Code app only free for the iPhone? No, it should be. I have the Galaxy products, Samsung Galaxy products, and you can download it on that. So I don't know what the problem with this, but no, it's not just iPhones. It's for all the smartphones. All right, moving right along. Intervertebral disc disorders, IVD. This is going to be conditions of displacements without myelopathy, Schmor's nodes, degeneration of IVD, disc displacement with myelopathy, and other unspecified disc disorders. This chapter, or this section, is M50 for cervical disc, M51 for thoracic, thoracolumbar, lumbar, and lumbosacral. Make sure that your documentation clearly states the specific condition and if there's any associated myelopathy or radiculopathy. And be very careful when you're coding here, because if you're using sciatica, sciatica actually has an excludes one that would say you can't use sciatica if the sciatica is due to a disc herniation or disc displacement. So this is be very careful, very detail oriented when you're using the disc diagnosis. Radiculopathy refers to a set of conditions in which one or more nerves are affected and do not work properly. This is our neuropathophysiology from our vertebral subluxation complex, and it starts with M54.1. And sciatica is a radiculopathy of sciatic nerve, M54.3. So these M50 codes, be sure to look those up very, very carefully. Myelopathy is a pathological process to the spinal cord, and it's going to have serious neurological symptoms and signs. There's going to typically be bilateral weakness of the extremity. There's going to be incoordination. There's going to be balance issues. Not totally uncommon with our Medicare patients. Again, where do we start in this whole process? Well, doctors, your starting point is going to be the history. So you're going to document chief complaint, mechanism of injury, past medical history, review of systems, family and social histories. You're going to get you into a clinical examination, a guide. There's going to have to be a flow chart manner of which you do your testing now. So again, I need you to go back, and if you're not using orthopedic and neurological exams, or you very rarely use them, go back and pick the ones that, your compression tests and your distraction tests, and review what those really are meant to elicit, and then how to document those. Because from now on, what I want you to, with your exam and your history process, your whole focus is what anatomical structure is causing the pain. And you can do that right now using ICD-9, and you're going to really be ready for ICD-10. So the 5 anatomical areas: is it a facet-mediated pain? Is it a facet joint? Is it discogenic? Is it dorsal root ganglion, or DRG, or our nerve root irritation? Is it myofascial? Is it visceral somatic? There's actually a 6th one, and I would call that chemical-mediated pain, and that's where there's the disc has been irritated so much that it's producing what they call a chemical soup, and it just irritates everything in the area. So start looking to isolate those anatomical structures. And it could be a combo plate with those too. It could be degenerative disc disease and facet syndrome causing the dorsal root ganglion to be irritated. Remember, the purpose of your history in your examination is to generate a problem-specific diagnosis. And if you start working on your hierarchy right now, neurological, structural, soft tissue, and pain, and focusing on what the anatomical site of pain is, your transition into ICD-10 is going to be very, very smooth. And if you start this right now, you're also, I believe, going to really help your current treatment plans, especially if you have any pre-authorization United Healthcare carriers. You know, a lot of times when they come back and say we're only giving you 4 to 6 visits, I typically look at the diagnosis, because the diagnosis is going to correlate to the treatment plan. And again, tissue differentiation, you know, so make sure that you just don't rush through the exam. Make sure that there's adequate interpretation of the clinical findings of your ortho and neuro tests, and then how to document those. And don't leave out those negative cervical compression or those negative Kemp tests if they have localized pain. Remember, incorrect interpretation of those orthopedic tests can lead to incorrect diagnosis, which leads to inaccurate treatments, because your treatments and your treatment plan should be totally based on the history and examination findings. So it's imperative as a physician to understand what reactions you're trying to elicit when applying a specific provocative maneuver or test. And as you get better, you're going to just do this in a nice flowchart differentiation manner. One of the best books that I ever read on this, I don't even know if it's still in print or if he's updated it, but it's Dr. Jeff Miller. He's a chiropractor and a DABCO, and he's spoken through the country numerous times, and I believe he used to lecture for foot levelers, but super, super nice guy. He had this book, Physical Assessment or Orthopedic Assessment, just an excellent, excellent book, and I always reference it because it really changed the way that I was doing my examinations years ago. So then your verbiage that you're going to use: cervical distraction was positive for relieving radiating pain in the upper extremities. Cervical distraction is positive for relieving localized pain felt in C5, C6 joints. Cervical distraction was positive for muscular pain. So these two up here are going to say or validate the existence of maybe spinal kinesial pathology, facet syndrome, maybe our neuropathophysiology when there's a dorsal root ganglion involved. And then this here was positive for muscular pain. That's myopathophysiciology.
Doctor,
Same thing with Kim's.
we have a question.
Okay.
Is there anything required for, say, Medicare patients in which order we list these diagnosis codes, such as primary codes, secondary codes, like we use now?
Oh, excellent question. Yes. When you order, there's a different order arrangement from Medicare as in compared to other group health insurances. Okay, so for Medicare, we always have to start off, and we always use the 739 series. Okay, so the 739 series is non-traumatic subluxations. And so you will always start off with a subluxation. So let's say that we have a patient that has low back pain, right sciatica, and they have muscle spasm, degenerative disc disease. I found subluxations in the lumbar, SI joints, and in the sacrum. So for that type of condition, I would start off with 739.3. That's going to be in my A slot because the new claim form has ABC. My B slot now, I go back to the hierarchy for my diagnosing. So I said that there was sciatica. That's the neurological diagnosis. And so I'm going to put, and I believe sciatica is 724.3. So that's going to go into my B slot. In my C slot, I'm coming back with another subluxation. So I said there was a pelvic subluxation, and that is going to be 739.5. And then D slot is going to be my structural. And so with the structural, I'm going to say there's degenerative disc disease, and that's going to be 722.52. And then E slot, I come back to my soft tissue. And that's going to be, did I say spasm? Let's just say spasm. And that's going to be 728.85. The F slot, I'm coming back to my sacrum subluxation, and that's going to be 739.4. And G slot then is going to be my pain, which is 724.2. So with that, I have 7 diagnoses, and I'm going to treat 3 to 4 areas, 98941. So I have enough diagnosis to support that. But with your Medicare, you're going to do subluxation and then do your hierarchy and then subluxation. So really, it's subluxation, condition, subluxation, condition, subluxation, condition. And then I would go through, if this was a full spine patient, then I would go to my next. So that was my chief complaint right there. Then I'd go to my secondary complaint, and if that was cervical spine, then I'd start off with H, and that would be 739.1, and then I just go through again with my diagnosing hierarchy. Any other questions on that? Okay.
I don't see any.
All right. Now, the correct verbiage, again, any of your compression tests, they have to produce radiating pain into the extremities. So if Kim's test was positive, there better be pain going down into one of the extremities. If it was negative for a radicular component, but they complained of localized pain in the facet joints, this is the correct verbiage to use. And then what we're doing is we're isolating the anatomical site. So with Kemp's or with your compression test, remember, any pain that's negative for radicular component, but there's localized pain, and then you do a distraction test and it relieves that, that's a facet syndrome. So start using that facet syndrome diagnosis more. So the diagnosis must support the patient's subjective symptomatology, the mechanism of injury, objective findings, and radiographic evaluations if necessary. The diagnosis should be as accurate as possible and express the etiology of the patient's condition. This was written in my documentation page textbook 4 years ago without ever knowing anything about ICD-10. So why, I bring that up because there's fundamental processes right now with your coding and your documentation that you can use for your ICD-9. So start putting those into play in your office right now, and that transition into ICD-10 is going to be made a lot easier.
Doctor,
and with that, yeah.
Oh, do we have a polling question?
We have a polling question.
All right. Everyone hold down your CTRL key, and I will launch the poll now. And while they're working on that, the doctor who asked about the primary and secondary codes and listing those commented and said, so we would just convert those to ICD-10 codes.
When the time comes for that, yes. Yes. So let's say that on September 30th, you have those ICD-9 codes. You're going to have to convert those to ICD-10 for October 1st. And, quite honestly, that is going to represent a challenge. because you are going to have to make those changes. I would recommend any of your patients that are in active care on that week and that they're right in the middle of a treatment program or they just started a treatment program, get those translations over to ICD-10 done as quickly as you can, because in a 24-hour period, you got to switch over a totally different language. If you're seeing any kind of volume, that could be a major, major headache to switch those diagnoses overnight.
Okay. We have 80% voted, so there's a handful out there who still need to get a vote in. I'm going to close the poll in a few seconds. So if you haven't voted, quickly click on something. Okay, we're getting close. 93% have voted. We've still got 2 or 3 more out there. 95, good. Anybody else? I'm going to close the poll now. And I will share the results.
All right. Now, Denise, pardon me, what was the second question for the poll?
Which of the following will drive ICD-10 selection to the most appropriate code?
Okay. All right. Really, the correct answer, if you chose 67% documentation, that's correct.
Awesome.
Documentation is going to drive. That's the reason any of your buddies that didn't attend this, or if you're out playing golf or whatever, and they're saying, "Yeah, I'm just gonna have this switch over. It's going to be, my CA, my insurance CA, my biller's going to take care of this." You need to set them straight. That's if you like them, because this isn't going to be something you can just delegate. If you don't plan and start doing the documentation better, it can cause an alteration in your revenue cycle, and I really don't want that to happen to anybody. All right, let's go through our review of the subluxation complex pretty quick, and then we'll get to our practice session. So just remember, what I want you to get away from is just putting down, especially on the new claim form, just putting down all subluxation diagnosis and then pain diagnosis. Break these down. Start breaking these down into these individual components. We're going to start off with our 739s, and then spinal kinesial pathology. Here's all these different ones that equate into spinal kinesial pathology. What's the orthopedic test that validates this? Restricted range of motion, either active or passive. And our negative compression test. Here's our segmental dysfunction codes for ICD-10. And you'll get to memorize these, M99 2, thoracic, 3, lumbar. So we'll get to the point we'll have these memorized like we did with our ICD-9s. Subluxations, we have our 7th character right here. There is an S code that actually says subluxation. We talked about that before. We don't know right now if they're going to allow us to use that or if we're going to stay with the dislocation. Right now, the mapping takes us already here. That could change, and we won't know that for quite some time yet. What goes into the 7th character? We've talked about the episode of care. Subluxations here again. Lumbar spine. And remember, these are traumatic. These are our traumatic subluxations. Here's an example of the sacrum, S33.2XX, and you're going to use X's, and then you'd use A, D, or S. These are our sacroiliac joints. We just call it the pelvet. But one SI joint that is subluxated, you would use these diagnoses. Neuropathophysiology, abnormal function of the neurological system. And in order to have these diagnoses that we're currently using right now, 723.4 or 724.3 or 724.4, you have to have either motor weakness and or sensory disturbances, and bring in some decreased reflexes as well. So this is why you have to do a neurological exam to substantiate a neurological diagnosis. Makes sense, doesn't it? When we get to ICD-10, you're going to need to be able to track those dermatomes. So you're going to have to refresh when you do shoulder abduction muscle testing. That's testing C5. When you do your biceps, C5, C6, because we need to be able to track that back up to isolate the anatomical site that's causing the pain. We have disturbances of skin. ICD-10 breaks this out into 6 different diagnoses. I do see where there's sometimes the translation from ICD-9 goes into more ICD-10 codes, but I've also seen where an ICD-10 code will replace 2 or 3 ICD-9 codes. Myopathology, so decreased active range of motion, antalgia, spasms. Here's our current codes we're using right now for this, and then here's our ICD-10. And this is just a small fraction of the myopathology diagnosis.
We have a question. Previously, you stated to be careful to use 723.2. What is an example of possible ortho to support?
What is that? Cervical cranial or cervical brachial syndrome? I think that's what it is. The reason that I say be careful, and I think that's it, to be careful of those cervical cranial and cervical brachial, is those are more advanced neurological conditions. That is not simply just neck pain and headaches. That's not just neck pain and arm pain. There's more neurological components that are going on with that. I would say in order to use that, you would need more neurodiagnostic testing to substantiate it. I do not believe that simple orthopedic or neurological of muscle strength testing, dermatome testing would support either one of those. Histopathology. So we have all of our disc problems, our sprains, and our facet syndromes. And again, I'm a big facet syndrome. I think that, well, I'm not a big facet syndrome. I'm a big facet syndrome believer. I think that the sprains are too general, and we've gotten just so used to using these very easy diagnoses like that. Start using those facet syndromes, especially with your auto cases. Those patients are having joint problems. They're more than just a soft tissue. And these here are going to be validated by our x-rays, especially with our disc degeneration, which actually comes up here, pathophysiology. All of these here, all these pathophysiology, all your degenerative process, all arthritis has to be validated by x-ray or MRI or CT scan findings. So unfortunately, what I see when I'm reviewing diagnosis with clients is that they'll have a nice radiology report and it'll state mild degenerative process at C5, C6, but they don't put it in the diagnostic area. So be sure, that's the only way that you can validate these, but these are these longer-term structural diagnoses that give you some wiggle room or explains why a patient may not be within that 90-day period that Medicare wants to afford you the opportunity. Again, get these into your diagnosis, into that hierarchy. And we go right here, ICD-9 to ICD-10 here. So let's go ahead and polling question number 3, if you're ready.
I am ready. If you'll hold down your CTRL key, I'll launch the poll now. And while everyone's answering, we do have a question. How current do x-rays need to be for Medicare?
That's another good question. They have to be, if there's a chronic condition that on that x-ray. So my interpretation of that is a chronic condition would be any arthritis, any degeneration. You can use that for as long as you want. They should be, it says reasonably approximate to the date of visit. I think in the manual it goes back 1 year. But that also is if you're going to use the x-ray to validate the existence of a subluxation. So I would say with any arthritis, with any degenerative process, if you have an older x-ray, as soon as that showed up on the film, you can use that x-ray to validate that diagnosis, because we know that's not going away. Patients aren't going to have degenerative disc disease from 5 years ago and you take an x-ray and all of a sudden it's gone.
Okay, we have 90% voted. There's a couple more out there who need to, a handful out there who need to get their votes in. So if you'll just do a quick choose so it registers you in my system, that would be great. I'm going to close the poll now. And if it didn't work for you, you can always send me the answer, put it in the questions box, whatever you need to do. So.
All right. Well, you need to start holding weekly meetings. DCs, doctors, make sure you update your interpretation documentation of your examinations. I highly recommend looking at electronic health records. That's going to make this transition so much easier. And continue with your training. So the correct answer on that was all of the above. And it is now time to play. Find that code. All right, so this is what you can do at your office. It doesn't have to be a boring process. You know, get some competitions going. Do some speed coding. So that, you know, you give the ICD 9 codes and say, okay, let's go. All right, so get your ICD 10 books out. And I want you to look up, find the ICD 10 code for pain in the neck. No, that's not what we... Okay, obviously that is the code, M54.2. I know why. Let's go through here. 81-year-old patient presents with spinal stenosis of the lumbar region. The appropriate ICD-10 code, M48.06, spinal stenosis. So I'm going to go through and give you some easy ones here that I give you the answer, and then we're going to actually start doing find that code. So rheumatoid arthritis, M06.9. Now, here we go. I want you to find 739.1, segmental dysfunction, cervical region. And I'll give you just a few moments to find that, and then I'll give you the answer. Now, I will give you a hint. With these, this is one area. This and the pain diagnosis is probably going to be the only time that I'll let you to either use the Find a Code app and come up. That'll give you a direct one-to-one, or your gems in the front part of the ICD-10 coding ChiroCode book, because it's a direct one-to-one. So the correct answer here is, anticipation is going, there we go, M99.01. Okay, now Remember, all good coders are detail-oriented. Make sure you read this, and let's find the ICD-10 for a traumatic subluxation of the fourth cervical vertebrae initial visit. I'll give you just a few moments here. And here we go. Okay, so we came up with the A. That's our episode of care because it was an initial visit. Let's look up brachial neuritis or radiculitis and cervical region. Be very detailed on this. This one here I'm going to give you a little bit more time because there is more codes that you're going to have to look up and rule out, I should say. All right. And if you are ready, now remember the site. If I would have had cervical thoracic, that would have been a different code here. So radiculopathy, cervical region. This should be an easy one. Again, the pain diagnosis, there's a direct one-on-one correlation in the GEMS. And there's the correct answer right there. Okay. Now be careful with this one. That's all it says is muscle spasm. Go ahead and give you a little time on this. So this is what I want you to do. Make a list, and you probably already have it, your favorites, your favorite ICD-9s. And, you know, maybe one office meeting you just do the segmental dysfunctions, the non-traumatic subluxations. And then the next one you do traumatic subluxations. And then the next one you do your structural diagnosis. And then your soft tissue, and then your pain diagnosis. And you just start translating and start building up a database of all your ICD-9 codes into ICD-10. What I do want you to start for sure now is start using the hierarchy of the diagnosis for ICD-9, and that way it'll make it so much easier for ICD-10. Now this was other muscle spasm because we didn't have anything over here. It didn't say it was a Charlie horse, and it didn't say back, so we're using other muscle spasm because we're going to assume that that's in the neck. There is one thing I need to tell you with soft tissue like the muscle spasm. You would never use these codes more than once. Even if there was a muscle spasm in the cervical, thoracic, lumbar spine, use it once for in the claim form and on your documentation, and that'll account for everything. Okay, let's see here. And let's go to 722.52, degeneration. And again, be very specific, site specific. So you would start off 722.52. You find it in the GEMS. So you look that up. And 722.52 is going to lead us to M51.36. So now you come back to the tabular listing, you go and find M51.36, but you just don't stop there. So M51.36, and make sure that you have the correct. Now we have lumbar intervertebral disc, and that's what it would be. M51.37 would have been lumbosacral region. So that's where, again, the site is very important. So let's say a patient presents with pain, weakness, numbness, tingling in both legs. Final diagnosis is bilateral sciatica. Okay, so let's go find that. Now, if you don't know you can start looking through M54s right away. And M54.3 gets us to sciatica. And if you see an ICD, or in the ICD-10 excludes 1, you cannot use a lesion of the sciatic nerve, which is G57.0, and you cannot use sciatica due to intervertebral disc disorder or any M51.1 codes. And you also can't use sciatica with lumbago. There's special sciatica codes now that have sciatica with low back pain. So the one that is bilateral would be M54. You would use both M54.31 and M54.32. So the question is, well, which one do you list first if it's bilateral? And you would use the dominant side first. So that's why it would be B.
Doctor, we have a question.
Yeah.
If you don't take x-rays, you can't use structural codes. Is that correct? Even if you've taken care of the patients for 20 years.
That's only if you're going to use a degenerative or an arthritis x-ray or a diagnosis. Your facet syndrome can be validated by the orthopedic compression tests that are negative for radicular pain, and your cervical distraction is causing relief of the pain. So you can use your facet syndromes without a diagnosis, and you can also use your structural, obviously your subluxation as a structural code too. I see there's another one. When you use the M54.4 codes because they had pain and sciatic pain on the last question. Well, let's take a look at that. Pain, weakness, numbness, tingling in both legs. All right, the final diagnosis. So we're giving you the final diagnosis right here, bilateral sciatica. And that's why you would use this. But see, this doesn't even tell, given just that information, that's the reason I put in here that there was I'm giving you the sciatica diagnosis. But the pain, weakness, numbness, and tingling in both legs, if I just left it at that, maybe that doesn't mean sciatica, right? Because we didn't get into what nerve root is being affected. We don't have any exam findings, muscle weakness, dermatome testing. We don't have any of that information. So Could it be a different one than the one given? No, because I gave you bilateral sciatica, but we know that this isn't real world. In the real world, patients come in with pain, weakness. That's why you do your examination. Okay. Well, we made it, guys. We made it through 4 sessions, but that's not the end of it. You know, keep your training up, and you know, I would love, and Denise, I'm putting a plug in here. I'd love to come back to Des Moines sometime and do some more sessions if you need us to. Plus, I want to stop off at Jethro's and get some good barbecue.
Yes, thank you. It looks like we got one other in. Will your new book address the orthos, radiologic components, complaint, etc., so we can do macros for our EHR?
Yes, yes, it will. It sure will.
Wonderful.
If you get your CAs hooked in, get them, you know, so that they're getting good quality coding education, get your documentation up, and remember our ICD 10 home study program, the discount. It's been a lot of fun working with you guys. Thank you very much, Denise, for the opportunity to work with such a fine group of doctors.
Thank you very much.